Hi, friends. So, in keeping with the uh, OSCE sessions, let's start with the few of the OSCE sessions in the MSK Radiology. This would be your first case. This is the relevant history which has been provided to you. Middle-aged male presented with intermittent episodes of knee pain, with few episodes of mechanical locking of the knee joint. On examination, there was no evidence of any tenderness or redness, and there was no evidence of any fever. So these images are basically provided to you. The first image is that of a lateral radiograph, while the other two are MRI images. Okay. So you can pause the video here and take some time to uh, try to reach the diagnosis. Okay. So these are the questions which have been asked about this condition. What is your diagnosis? What is the most common location for this uh, incidental finding or the pathology? Name two differentials, and what is the first and second line of management in this case? Okay. So this is a case of meniscal ossicle. Uh, the second question, that's the most common location, which is your posterior horn of the medial meniscus. Two very simple differentials. One is your intra-articular loose bodies. Other one is the fracture. First line of management is your conservative, and second line is your if it's uh, very symptomatic, you can proceed with arthroscopic resection as well. So now let us discuss the findings and then a brief about the meniscal ossicles. Okay. How do you describe this radiograph? If you get this as a short case in your exams, you will say it's a lateral radiograph of the knee joint of a skeletally mature patient showing a well-defined. So this is your pathology. You can see a well-defined triangular radiopacity involving the posterior aspect of the tibiofemoral joint space. Since they have not provided you with the AP radiograph, so you cannot comment whether it's a medial tibiofemoral joint space or the lateral tibiofemoral joint space. So since only the lateral radiograph is provided to you, so you will just write it's a well-defined triangular radiopacity involving the posterior aspect of the tibiofemoral joint space. The rest you can see it's the rest of the knee is unremarkable. You cannot see any other abnormalities. Proceeding with the MRI, the left image is basically your sagittal PD image, okay, and the right one is basically your axial PD fat set image. So what do we see? If you look closely, we can see an altered signal intensity area within the horn of the meniscus. Okay, since the axial image is provided to you, so you can easily guess the location. So this is your posterior horn of the medial meniscus. Okay, so you can see there's a triangular altered signal intensity area or structure within the posterior horn of the medial meniscus. And what's the marrow signal? Okay, if you look very carefully, the signal of that lesion is exactly similar to that of the corresponding marrow. Okay, so a well-defined altered signal intensity lesion within the posterior horn of the medial meniscus, having a signal which is same to the which is following basically the marrow signal on all the sequences. Okay, and if you look very carefully, you cannot visualize the fibers of the posterior horn here. Okay, so there are and also you cannot visualize your root fibers in this lesion. Okay. So this is your boundary of the meniscus. Okay. So this is the lesion in the posterior horn of the medial meniscus. And here you should have seen the root fibers. So there are no root fibers which are seen. That's an additional finding. Okay. So let us discuss in brief about what are meniscus ossicles. So these are usually very rare incidental findings. They're usually asymptomatic, but may present with sometimes with intermittent pain or rarely joint locking because sometimes they can grow large and can cause irritation to the movement of the knee joint. The most common location, which I've already told you, that was one of your questions, that was within the posterior horn of the medial meniscus. There's a reason why, because this is one of the most abundant uh, area of vascularity and also the most damaged meniscal tissue. Okay, so since it's an area of abundant vascularity, plus it's also the most damaged meniscal tissue, so this both of these predispose it to dystrophic ossification in this location. So this is one of these are the two reasons why this is the most common location for the formation of a meniscal ossicle. There are various theories of origin, not very important. Some people say that's a degenerative, it's because of the mucoid degeneration of the meniscus. Some say it's a vestigial structure, but the most followed or the most accepted theory is your post-traumatic one. Okay, so there's a heterotrophic ossification or a dystrophic ossification of the osseous avulsion of the meniscal root attachment to the tibia. If you proceed with the imaging, if you have MRI, then MRI is the modality of choice, and it will conclusively diagnose your meniscal ossicles. Okay. On X-rays, you have two differentials. One is your intra-articular loose bodies, and other one being your fracture fragments. Okay. But on MRI, there are no DDs. Okay, it will conclusively give you the location of the structure as well as your signal intensity, which will match the marrow signal on all sequences. So it will conclusively diagnose meniscal ossicles and will rule out any fracture fragment or your intra-articular loose bodies. So the most key finding is well-defined structure within the substance of the meniscus with a signal intensity identical to the normal bone marrow. Okay, so these three findings: number one, well-defined structure. Okay, in the substance of meniscus. And thirdly, signal same as marrow. So let us proceed with the differentials, which I've already told you. These are just two differentials on X-rays only. If you have MRI, you can conclusively diagnose meniscal ossicle, but if on X-ray, we can have differentials of like fracture fragment, intra-articular loop bodies. Okay, it's very easy to differentiate between the meniscal ossicle and fracture fragments because meniscal ossicle will usually have smooth margins, while fracture fragments will be having your irregular or crenated margins. In a meniscal ossicle, you will not be able to see any donor site, that is from where the fracture fragment has uh, been swept away. So there will be no donor site in case of meniscal ossicle, but from fracture fragment, you will be able to see the donor site from where the fracture fragment has originated. Okay, so that will be either in the femur or tibia. Okay, and this is basically on the basis of MRI. Okay, you will conclusively find that this meniscal ossicle is located within the meniscus. Okay, but the fracture fragment as well as the intra-articular loose body will be located either just adjacent to the meniscus or away from the meniscus. They will never be located within the substance of the meniscus. So that is why MRI provides the most conclusive finding for the diagnosis of meniscal ossicle. Okay. On X-rays, intra-articular loose body will also have smooth margin. Now, the most common reasons for intra-articular loose body is an osteochondral defect, which you will be able to see as a donor site on again femur and tibia. Okay, so differentiating between both these two, that the fracture fragment will be having irregular margins plus the donor site, while intra-articular loose body will be having smooth margin plus the donor site. Okay. So take home message on X-ray, you can commonly confuse it with the intra-articular loose body. MRI will conclusively make the diagnosis. And a very important point for all the radiologists out there, if you find the presence of a meniscal ossicle in a case, you should definitely carefully look for a meniscal root tear, since the most common location is the posterior horn. So the most common tears which are associated with the presence of a meniscal ossicle is the tear of the posterior root of the medial meniscus. Okay, so if you find a meniscal ossicle, definitely search for a posterior root tear. So that was all for this case. Thank you.